So today we're going to talk about how to manage your knee pain and how to enjoy an active lifestyle. Can everyone hear me okay?
Yes.
Yeah. So the objectives, the things that we're going to cover in this talk tonight, we're going to review the basic anatomy of the knee joint. We're going to define for you what is osteoarthritis. We will review some of the most common treatment options. One of them is included hyaluronic acid injection therapy. And then we'll talk about some other more advanced treatment options, including a genicular nerve block. So to start, this is a diagram of your knee joint. And you can see here that the knee is made up of 4 different bones. So this is the femur bone here. This is the tibia, and this is the fibula, or the smaller bone on the outside or lateral aspect of the calf. And this is the patella, or the kneecap. So there are really 2 functional joints in the knee. There's the femoral tibial joint, so the larger joint here. I don't know if you can see the arrow here. And then the femoral patellar joint, which is here under the kneecap. There's also cartilage around the knee, and this helps to decrease the frictional forces as movement occurs between the bones. And then there's a synovial membrane that lines the joint, and this produces or secretes synovial fluid, which again helps to reduce friction and facilitate movement at this joint. There are also many ligaments that surround the knee and are important in stabilizing the knee joint. So the 2 that cross here in the middle is the ACL and PCL, anterior and posterior cruciate ligaments. And then on the medial aspect, or the inside of the knee, over here, you can see the MCL. And the lateral aspect, or the outside of the knee, is the LCL. And then there are several other smaller capsular ligaments. And then there are the medial and lateral meniscus. So they are found, let's see where they're here. Here's the pointer, in here. And they help with shock absorption in the knee joint. So what is the leading cause of knee pain? So if you look across the U.S., the leading cause, the #1 reason people complain of knee pain is really osteoarthritis. So that's what we're going to focus on in tonight's talk. So knee osteoarthritis is the most common form of osteoarthritis and is a major cause of disability in the United States. About 30% of people over the age of 50 will have evidence of osteoarthritis on imaging, namely x-rays of the knee joint. And about 80% of people over the age of 65 will also have these findings. And it's more prevalent, it's twice as high in women in this age group over the age of 65, and that's thought to be related to the hormonal changes after menopause. So to review, what are some of the most common symptoms of knee osteoarthritis? So commonly people complain about knee pain, as well as knee stiffness, particularly in the morning or after sitting for a prolonged period of time. They also may have swelling and inflammation of the affected knee and difficulty with everyday activities. So again, getting up from a sitting position or particularly stairs may become problematic secondary to knee osteoarthritis. So what is osteoarthritis? Again, it's the most common form of arthritis, and it's also known as wear and tear arthritis. It's characterized by the breakdown of the joint's cartilage, and the cartilage cushions the ends of the bones and is what allows for easy movement of the joints. It also is characterized by diminished joint fluid. So this diagram here shows a healthy knee joint. You can see the cartilage is intact and there's a lot of healthy synovial or joint fluid there. This diagram now shows mild to moderate knee osteoarthritis. So you can see that the cartilage has eroded somewhat and the synovial fluid is now decreased and is not as healthy. So as the disease progresses, the joint fluid becomes less healthy, and again, the cartilage begins to break down. Pieces of the bone and cartilage can actually break off and float around in the joint, and you also may develop what's called bone spurs or growths of the joint. This is a diagram, again, as the disease progresses further to severe knee osteoarthritis. And here the cartilage may be completely worn away and the bones may rub together. This patient would be a likely candidate for a total knee replacement. You can see the cartilage has eroded, there's almost no joint fluid, and you can see the bone spurs or the overgrowth of the bone here. So knee osteoarthritis has significant physical and emotional impacts for the patient. So some people have weight gain due to their inability to exercise, and then weight gain can then exacerbate the knee pain and the osteoarthritis. So for every 1 pound of extra weight that somebody carries around, it translates to an extra 4 pounds of weight on the knee joint. So if someone gains an extra 10 pounds, that's an extra 40 pounds of stress on the knee joint, so it becomes very significant. Other people may become depressed due to their pain or lose sleep due to their pain. And both depression and sleep disturbances can also worsen the pain. It can also affect relationships, productivity, and public safety if people are not getting enough sleep. So now I'm going to start to review some of the early stages of treatment options. So to start, there are a number of alternative therapies or herbal medications that can be helpful. So glucosamine and chondroitin sulfate are commonly advertised to help with knee pain. There are a number of other herbal remedies such as fish oil that can be helpful. Sometimes topical capsaicin can be helpful. Massage can be helpful, and actually acupuncture can also be helpful. And all of these things offer temporary pain relief. In general, they're pretty safe, but anytime you take any type of medication, even if it's an herbal supplement, it may cause side effects, and in particular, it may interact with other medications you're taking. So it's important to talk to your physician if you are using any of these products. The next thing are non-drug therapies and analgesics. So, as I mentioned before, diet and weight loss are very important. And then exercise, so physical therapy is very important. So strengthening exercises to keep the muscles strong that support the joint, and also stretching exercises to maintain good range of motion and flexibility of the joint are all important. And then there are a number of over-the-counter drugs or medications that can be helpful. So these include things like Tylenol and NSAIDs, or anti-inflammatory medications. Common ones are ibuprofen and Aleve. In general, these medications are very safe, but again, any medication can have side effects. Tylenol at very high doses can cause liver problems. And then aspirin or other anti-inflammatory medications can cause GI or stomach problems, and also kidney problems, particularly if it's high doses and prolonged periods of time. Again, these therapies are helpful to provide temporary pain relief. The next step is really prescription medications. So COX-2 inhibitors are one class of prescription medications. The common one here is Celebrex. And then narcotics or opioid pain medications may also be used. Again, both medication classes can be associated with side effects. Medications like Celebrex, again, can cause GI upset. Again, can cause some kidney problems, or possibly cause cardiovascular problems, again, at very high doses and for prolonged periods of time. And then opioids or narcotic painkillers can also be associated with a number of side effects. So it can make you drowsy, it can cause dependence, addiction, tolerance, it can cause constipation, a number of significant problems, again, at particularly high doses. All of these medications can be helpful for temporary pain relief. And then the next thing we'd like to talk about in terms of treatment options are steroid injections. So this is a very safe in-office procedure that has the potential to provide more prolonged pain relief, particularly 1 to 3 months of pain relief. So now I'm going to pass it over to Dr. Mehta, who's going to talk a little bit more about different injections that may be helpful.
So just a show of hands here as to who's had knee surgery before. So 2, 3, 4 people. And who has had a knee injection before? And how many people have had some sort of artificial cartilage or injected in there? Okay, one person. All right, good. Just so we have an idea. So for many of you who have had a knee injection before, as Dr. Witkin mentioned, this is a use of steroid into the knee. The idea of the steroid is an anti-inflammatory. So potentially the bone rubbing on bone, or even some of the fluid in there, is creating a lot of swelling and inflammation in the joint, and we are injecting something very concentrated and into the particular problem area that can reduce that swelling and potentially reduce the inflammation, and therefore lead to reducing pain. Now, how long does that last? Well, it can last anywhere from 2 to 3 months on average. That means that on average, because it's a bell curve, some will actually receive benefit for a year or longer, and some will receive benefit for a day, if that. Okay? Our hope is that we're getting somewhere in that 2 to 3 months range. And the reason that we hope that is that there's a ceiling on how many we can give you in a given year. And that is because of the steroid itself. So steroid is naturally produced in your body. We're just supplementing a little bit more and concentrating it to the area. If you end up having steroid injections, you're boosting the amount of steroid produced in your body, or boosting steroid in your body, and may actually cause your body's production of steroid to go down a little bit, which can actually be really problematic. So this includes other steroid injections. This includes if you are having epidural injections of steroid, or if you're having your shoulder joint injected, or if you have severe asthma and you're taking steroid for that. So it's very important to discuss with your doctor about the other types of cortisone or steroid, or various terms that are thrown around as to what you're getting injected and where, and when the most recent one was. So therefore, the idea is that the pain relief lasts from about 6 to 12 weeks. We limit the amount of usage that we do this for, and also we look at how much you've had over time before we decide about doing the next step. So what we're doing is essentially injecting the steroid right into the, let me see if I can do it, right down here into the knee itself. Now you can do this in a few different ways. Number one is you can do it right in the office, what we call a blind technique. We feel where the landmarks are and inject right into it. And most of the time that works pretty well. But sometimes if your knee's anatomy is a little different, we may choose to use some image guidance using a different device to help us locate where exactly we're going to inject. And that can be either X-ray or ultrasound. X-ray is pretty safe because we're not using a lot of radiation, just 1 or 2 images to get in. Or ultrasound, which also can show the same anatomy and has no radiation involved. But the two are pretty comparable, and depending on where you have your injection done in terms of the office, you may see one or other type of device. So let's go on. So what sort of things would prevent you from having a knee injection? Well, this goes for any type of infection, whether it's in the knee joint itself, or if you're suffering from a pretty major infection somewhere else in your body, it's not a good time to have a cortisone injection. That being because the steroid actually can suppress your immune response, and that's why we're trying to avoid making that infection any worse than it particularly is. The second thing is we don't want to cause any spread of that infection with the needle into your bloodstream and have it spread elsewhere in your body. The other thing we want to make sure is, have you had these injections before and really haven't had relief? You know, sometimes doing the same thing over and over again really isn't going to produce a different benefit. It's reasonable. Sometimes there's a little bit of operator dependence, meaning your doctor just didn't have a little luck on his side that time, or something else was going on, and that's why it's worthwhile to try a second time. But beyond that, it probably is not worth it, especially if you're only getting a short amount of time out of it. And then the other thing is that if you are on any sort of blood thinner, Plavix, Coumadin, and all the new drugs that are out there, your doctor should definitely be aware of that. And there may be a time period that you have to stop that blood thinner before you have the injection. So let's go on to the next phase, talking about hyaluronic acid. So this is also, again, another office-based procedure. And the idea is that we're going to extend the life of that knee injection by changing the medication type, using something that is a little bit closer to our natural cartilage than just steroid. And some of the more common names that are thrown around as brand is Orthovisc and Monovisc. Okay? The same sort of risk can apply in terms of infection, bleeding, bruising in the knee. You could accumulate fluid into the joint. So what is hyaluronic acid? This is basically very similar to the naturally found joint fluid that you have that unfortunately as we get older is wearing away. And therefore its goal is to act as a lubricant or shock absorber into your joint. When you actually feel the medication, it kind of feels like a little bit like a lubricant. It feels pretty slippery that way. And therefore, we're trying to supplement what you had in there before. So Orthovisc is FDA approved. It's a viscous, thick, sterile mixture, and we are injecting it into the knee joint. Now, some of the brands that make this drug, some are derived from birds, and some are actually synthetically created. You can discuss that with your doctor as to which one is better for you. There's no buffers or preservatives, and the idea is that this can last up to 6 months. Orthovisc is actually a series of injections, so you actually will come in every couple of weeks and have a supplement to have it build up in your system and last long enough for the 6 months there. Monovisc is fairly new to the market, and that is a similar type drug, but now is a single injection. So the idea is that what once used to be every 2 weeks up to 3 times in a row can be replaced with one injection. Now, some of the use of this stuff is dependent on your insurance companies and approval from them as to which one they will allow you to use. So how does it work to relieve pain? Again, it's trying to replace the synovial fluid. It's supplementing the hyaluronic acid in there, and again, trying to last about 6 months of pain there. As we talked about before, some of the reasons you wouldn't want to use it: if you have an ongoing infection, if you have allergies to hyaluronic products, or gram-positive bacterial proteins. Okay? Then we talk about knee surgery. And knee surgery is basically replacing the joint, shaving part of the bone, adding in a prosthesis in there, and to replace the joint. And I'd say every few years they're making progress on the size of the prosthesis and how much bone they actually have to remove. There are sometimes partial knee replacements, so that if only one side is bad, they can actually replace just that part. Again, this is a surgical procedure under anesthesia. It has some recovery time, involves physical therapy afterwards, and you would see your orthopedic surgeon to discuss further about that. But generally, this is further down the road once you've exhausted a lot of the other options that we've discussed already. Now, there's a certain category of patients that will have knee surgery, or they're not a candidate for knee surgery, and they continue to have pain despite all the things we've talked about before. So what can we do for them? Well, there's a fairly new procedure that's come around. It's called a genicular nerve block. And what we're essentially doing is we're looking at the knee anatomy here. There's a knee joint right there, and we're looking at the nerve supply from each side. So there's 2 nerves from above and 2 from the side there, and there's a 5th branch that comes around from the middle that we're trying to block. And that idea is that these are nerves that really are just providing sensation to the joint. They allow you to feel the joint, but they're not actually controlling your knee or moving your leg. So you actually can potentially block these with a nerve block and see if that provides pain relief for you. What we would do is a test block where under x-ray guidance we would place a little bit of local anesthetic, which means essentially like Novocaine, and see if you get temporary pain relief from that. And when we say a meaningful amount of pain relief, we're looking for something greater than 50%. So it's something that you may know that the pain is still there, but it's definitely better than before. You may not have it completely gone. So if that were to work, then we'd move on to something a little bit more permanent. And here you see the X-ray guidance of the needles actually coming in. This is the outside of your knee joint. This is the inside. So we have a needle up here, and then one down below. This is a side view of that, going to about the middle of the joint there, and blocking that nerve. So then we move on to something called radiofrequency ablation, which some people may have heard about from prior talks that we've had here for back pain. The idea is that you're using a high frequency electrical current to essentially kind of stun the nerve there. Destroy the nerves sounds like it's a permanent thing. Actually, these nerves unfortunately do come back, but we use heat to heat the nerve up and potentially stop that transmission of pain through that area to your brain. The way we do it is, again, under X-ray guidance. We test the needle placement to make sure we're not capturing any muscle that's going to be affected by the heat. And then we numb the area again and then heat the area. So here is our actual device that is there sitting for the knee joint. And you can see the kneecap right here, and then the two needles on the outside. Sorry, this is the inside actually, and then here's the outside. Trying to heat that area. This is done as an outpatient procedure. It takes about half an hour at the most from start to finish. So the number one thing that you guys can do is, again, being active and trying to keep your weight under control. Your knees are carrying your whole upper body, so obviously they can get worn out. You want to see how much you can actually walk, bending at the hips and knees to see if that brings on pain. Movement even in a seated position to see if that elicits pain, so acting as if you're stepping on the accelerator of a car. And then doing a twisting motion with your knee, such as if you were about to tee off from the golf course. And if some of these things are causing you significant pain, this is what you would address with your doctor. Okay. So in summary, there are a host of conservative treatments that can potentially help your knee pain. And some of these can actually help you for years to come. Weight loss is probably the number one thing that we can all benefit from for various reasons. And you can talk to your doctors about the treatment overall. And if, in case you want to come see us, this is our number. We have an office here upstairs on the 10th floor. We also have an office downtown where Dr. Witkin is the director at Lower Manhattan Hospital, the old, what is it, Beekman Hospital, right? New York Downtown Hospital, Beekman Hospital. And then we also have an office on the Upper West Side on 84th Street and Broadway. So with that, I'm going to open it up to questions and ask Dr. Witkin to come join. Yes, sir.